Good afternoon. Welcome to everyone. First of all, I thank you, our President, and all our office bearers of IMA, national and state leaders. So today is a special program, special event for the inauguration of fellowship courses on arthroplasty, infertility, and regenerative medicine. I thank all the office bearers for this wonderful opportunity to spread the knowledge across our country. This is the program. May I welcome our Chairman IMA AMS, Dr. Rajesh Babu sir, for the welcome address. Dr. Rajesh Babu sir is a senior consultant neurosurgeon and head of the department in Ganga Hospital, Coimbatore. Dr. Rajesh Babu sir is a former president of IMA Coimbatore and chairman of Organ Donation Committee, as well as the IMA AMS chairman. Over to Rajesh Babu sir for the welcome address.
Good afternoon, everybody. First of all, I welcome our president, Dr. K.M. Abul Hasan sir, for this nice webinar, which we are conducting for inaugurating the courses of IMA AMS. I welcome other office bearers, our secretary, the treasurer, Dr. Gauri Shankar, and the president-elect and past presidents. And I welcome Dr. Gunasekharan sir, the national vice president. The main aim of our IMA AMS is to help our IMA members to utilize the services of the specialty services. That is the main aim of our IMA AMS. And consequently, now I am there for 5 years, and we are conducting different courses. And this year we are starting with the courses. One course, the laparoscopic IMA course. The ARTHIMA is already started, and we are going to have the initial class in the next week. And 2 students already joined there. And we are already started this DIARIMA is a diabetic retinopathy course, which is conducted by Dr. Kosal Ram. And the people are joining. And now we are going to start the 3 more courses, which one is Arthroplasty course by Dr. Rex from Rex Hospital, and Infertility course, Infertility INFERIMA, which is started from Coimbatore Rao Hospital, Dr. ASHA R madam, and Regenerative Medicine course by Dr. Ravi Regima. We are starting the 3 courses, and it will be started from October 1st onwards. We will be starting. I welcome you all for this program and utilize the services. And I request all the people who are on the specialties, please become member of the IMA AMS so that we will have a huge representation in our national level. Thank you, one and all.
Thank you, Chairman sir. May I invite our IMA TNSB State President, Dr. Abul Hasan sir, for the inauguration of IMA AMS Fellowship Certificate course in Arthroplasty, Infertility, and Regenerative Medicine, and the President's address. Over to Dr. K.M. Abul Hasan sir.
Thank you, Dr. Jayaraman. Good evening, all of you. All the office bearers of Tamil Nadu IMA and also TNSB and also IMA AMS, and the faculties, Dr. Rex, Dr. ASHA R, and Dr. Ravi. I'm really very excited about the very specialized courses being started in AMS. I wish that this kind of courses will develop, will have so much of attraction for the people of IMA towards AMS. I think the other courses, whatever Dr. Rajesh also, I think would definitely useful to the members. I only wish at this juncture that, while developing this kind of specialized courses, we should have a very pakka curriculum and content. For example, when I was AMS secretary, I started this endoscopy and laparoscopy courses where we developed a book of curriculum and content. So then only it will be very successful. I hope our team would have by this time developed it. If not developed, I think it should be developed and then printed and given to the course delegates who are willing to do that. Then only it will be very successful. Please take care of this point. And at this juncture, I also thank our faculties, Dr. Rex, Dr. ASHA R, and also Dr. Ravi for sparing their precious time and accepting our invitation to conduct these courses. I wish all the delegates have a good time. Thank you, AMS, for giving me this opportunity to inaugurate these 3 courses. Thank you very much. Over to you, Dr. Jaram.
Thank you very much, President, sir. We'll follow all your advice, sir. Thank you, sir. So these are all various courses under the, we are going to form the course modules and application. Everything is there. So very soon we are going to start all the specialty courses in each and every hospital. I request all the consultant specialists, those who are in practicing in a specialist hospital like a tertiary or coronary care hospital, to kindly go through and start these kind of courses for our own IMA members. So these are the short-term courses, 6 months to 1 year courses, both offline and online courses. Eligibility criteria, all the guidelines is there in the bylaws book. So periodically we are posting all our IMA WhatsApp group. Kindly go through. Any clarification, please call me. So with that, I conclude my talk. Any queries, please feel free to ask me. With that, I hand over the mic to our Joint Secretary, Dr. Adar Kumar, for the same proceedings.
So thank you very much, sir. We'll go to the first session of update in arthroplasty.
Vice President of National IMA, Dr. Gunasekharan sir, for the felicitation. Gunasekharan sir, kindly unmute.
Good evening, everyone. Respected State President, Chairman of the AMS, Dr. Rajesh, Secretary Jayaraman, Adar Sendil, and all the faculty members and the members who are attending today in large numbers. I congratulate the IMA AMS team for inaugurating today's arthroscopy, infertility, and regenerative medicine courses for the use of our members. I wholeheartedly congratulate and my best wishes for the useful. Rex already last week only he visited Trichy and enlightened our members on the clinical ortho signs and symptoms. So he is a very good teacher and an arthroscopic expert in Coimbatore. I hope he and Dr. ASHA R and Dr. Ravi, who is doing in the field of regenerative medicine, Ravi, they will all be useful for our IMA AMS members for getting more knowledge in the respective subjects. With this, I congratulate the team and best wishes for the team. Thank you.
Thank you very much, Vice President, sir.
Thank you very much, sir. Thank you very much, Dr. Gunasekharan, sir, for accepting the next week webinar.
Yes,
Neuro
thank you.
Session, sir. Thank you very much, sir. Thank you, sir. Happy to introduce our senior person in orthopedics, Dr. Rex, Senior Orthopedic Professor, Head of the Department of Orthopedics in Rexortho Hospital. Nearly 20 pages of CV from him I received. It's very difficult for me to read the whole session, just a clinch. He has presented more than 400 lectures all over India, and he has received gold medals in most of the orthopedic conferences. He published more than 40 articles in the national and international level. His academic positions are enormous. He was the editor, past president, and he has presented in so many topics in Journal of Orthopedics and Joint Surgery, and he was the examiner for the post-doctoral fellowship in arthroplasty and arthroscopy for the Dr. MGR Medical University and DNB Ortho exam conducted by the National Board of Examinations, New Delhi. With this, I invite Dr. Rex for his talk on recent update in arthroplasty. Over to Dr. Rex.
Yes, sir.
Yes.
Rex, sir, very little person. Congratulations, sir.
Thank
and the entire team, best wishes, sir. Sorry, sir, I'm in an emergency. I just wanted to come to wish you all.
Thank you, sir. Please,
Thank
you.
Thank you, sir. Thank you, sir.
Thank you, sir.
Yes, sir. Rex, sir. Over to you.
Okay, sir. Good evening, everyone. Respected President, Dr. Abul Hassan, sir, Secretary of IMA, AMS, Dr. Jayaraman, sir, and Chairman Dr. Rajesh Babu, who has taken the big initiative of program getting it roped up so many specialties members. Thank all the office bearers for giving this opportunity to start this fellowship on arthroplasty. So today I'll just enlighten about the what is going on in arthroplasty. So this is just going to be a nutshell to tell or to enlighten all the IMA members out of the specialty to know what's happening in the orthopedic, especially joint replacements. Joint replacement has become very common nowadays. In the past 20 years back, if you ask me, very little people are willing for any joint replacements because they're so scared of removing the joint and putting a new joint in. And only few people opted or volunteered themselves for the procedure, and they tend to live with the pain for the rest of their life with immobility. The life is mobility and mobility is life. And when you become immobile, you catch up all the illness and you end up in a big problem. But the days have gone now. Because the media or the awareness, I should say, with all the orthopedic surgeons, telling the public the advantages of the joint replacement. Now, most of the patients, they come at a very early phase of arthritis to get it treated. So they don't end up in end stage arthritis. So that is really good. So it doesn't become a very disabling problem nowadays. So that's what I want to tell. But still, because of the longevity of life, we see a lot of elderly patients. They come up even at the age of 95, 100 or 105 years. Even at 108 years, we have done a joint replacement because of the independent activity, or they are pushed to do things because they are very independent on their own and nobody is there to take care of them. They live on their own. They want to have a peaceful, pain-free life. So that is what it is. So we know the real indications for joint replacement is intolerable pain or failed management with all the conservative means. You try with all the conservative method of management of pain, with the painkillers, injections, physiotherapy, and with all this, if it doesn't work and the patient comes to the very end stage arthritis, exhausted all the measures of conservative management, obviously they may need something more. So pain is the most important indication for which we do. The second thing is sometimes the deformity. Some patients have a severe varus or valgus deformity in the knees, which is very disabling and they're not able to propel themselves. So those patients, yes, definitely we volunteer, we give them the option of joint replacement. So this is basically to improve the quality of life and the everyday necessity, the life, the day-to-day life activities. Definitely if it becomes impaired, then possibly that is the time really you tell them that you need a joint replacement. But there are a few exemptions. Some patients, because they want to have a, for the work what they do, or to earn their life, they may need to do a joint replacement. So there are few relative indications as well. And obviously osteoarthritis is a very common cause, especially in the knee. But sometimes we do in hip as well, for most common being the rheumatoid arthritis. And there are various other reasons like, shattered fractures in the very elderly population, or failed reconstructions and tumors. And sometimes even a revision hips and knee replacements are nowadays become very common. But there are obvious contraindications like, patients who are unfit for any surgery, obviously you don't do. Physiological age, it varies, see, that's what I said. Patients who are physically very active, even at the age of 105, I have done, and 108 is the, the age which you have done. And also the youngest age which you have done is 12 years. So, and the arthritis, or because any problem other than arthritis is an absolute contraindication. Any active infection in the local area, neuropathic joints, or loss of muscle power, or neurologically, the patient has got a severe problem, you cannot do a joint replacement. And joint replacement the biggest worry is infection. You don't want the patient to catch up infection. So the preparation of the patient, the surgical team and theater is very, very, very important. It's not as like any other surgery, you just post them and do it. You always prepare the patient, you counsel them and make sure the patient is the best health before you go in for a procedure. And so screening the patient is very important. So medically you evaluate to find out any septic focus or any distant focus, which can be a problem like urinary infection, and dental evaluation you try to do. And obviously you look at the DVT prophylaxis, because some patients can have a previous, DVTs or varicose veins, or because of the obesity, you may need to consider for a deep vein thrombosis prophylaxis. So you need to do a complete workup for this patient, what I'm going to do, and what are the ways I can prevent the complications. So this is how you look at. And also preoperative plan of the procedure also is very important. What type of implant I'm going to select, and will this implant suits the patient or not, and what is the bone quality. So many things you look at the patient to find out the local causes or the distant causes or general causes which can cause the problem for the patient. Now, preparing the theater again is very, very important. All the orthopedic theaters should be kept 100% sterile, no doubt at all. It's not that you do a joint replacement after doing an non-orthopedic case in the theater. So if you have a general theater, possibly you should do as a first case in the morning. But if you have exclusive orthopedic theater with a typical laminar airflow, and use all the exhaust, astronaut chutes like the Charlie chutes, and have exhaust gowns, and you have a double draping, double gloving, and you take all the precautions to do it completely in a aseptic technique. And the patients may have other coexisting morbidities, like this patient, without knowing, you post them in theater, and this patient lie down on the bed, the head touching down. And the anesthesia should not be stunned looking at the theater that this patient doesn't have any neck movements at all. So you cannot intubate the patient. So it is a good preoperative assessment, and a preoperative assessment including not only by the orthopedic surgeon, by the anesthetist, the medical team is very important. So they must be well prepared or aware of the problems. And this patient may need a fiber optics to intubate. So many things. And also you cannot do a spinal anesthesia for a patient with ankylosing spondylitis. So you need to think in all different ways to find out what are the problems we can come across this patient. And especially a patient with rheumatoid arthritis may have an atlantoaxial problem, and it's not sublux when you do a intubation of the patient. So you need to have a neck X-ray. So all these are very important when you do a preoperative assessment. Total hip replacement is not new. In 1956, John Charnley came out in Manchester with a new concept of having a small ball with a big cup, and this really revolutionized the management of total hip replacement, and he's the pioneer in hip replacement. I am very fortunate to get trained in Manchester myself by the associates, and learned a lot of techniques about the pioneering hip replacement. And we tend to do in a lateral position, which was many times it's done in the posterior approach. So this is one of the initial hip replacements with a fully cemented total hip replacement. Even now, I could say that I've seen the longest hip replacement survival of more than 54 years, and done by John Charnley himself. So that is the result of total hip replacement. So this is the patient who had a bilateral ankylosing spondylitis, had a bilateral hip replacement done in same sitting, which is a big advantage when you do a hip replacement position. Sometimes the surgeons, they do in the lateral position, and you need to space out or stagger the other joint replacement by giving some time, but really not necessary if you're doing a supine position joint replacement same time. So typical stooping posture, the patient cannot have a straight gaze because of the severe kyphosis of the cervicothoracic junction, and severe arthritis. And after the correcting doing a bilateral hip replacement, you can see he's able to have a straight gaze, and so that is a big advantage of doing a hip replacement, and really changes the life of the patient. So sometimes bilateral we tend to do depending on the fitness of the patient. Now the hips have come across, we have seen the cemented hips in the past, but nowadays we tend to do a lot of uncemented hips. When I say uncemented, you can see the stem is porous coated. Here the stem is porous coated, and it's a snug fix on the femoral side, and our own bone grow in and fix the component. So because the biology keeps remodeling every time, so the stem doesn't get loosened, which is the biggest problem in cemented hip replacements. And also the head nowadays use a ceramic head, which is highly polished in the world, and it has a long life with almost a nil wear, I would say, and almost like like a normal hip normal joints what you have. So that is the biggest advantage of using the latest metallurgy and having the ceramics on ceramic head. At one point of time, we were doing a lot of resurfacing hip replacement, which is another thing which has got a limited indications nowadays. Only patients who are with a high profile activity like athletics, they want to pursue their career for a few years, like 5 years, 10 years, and then go in for hip replacement. Possibly, this is one of the indications we call the resurfacing hip replacement. Well, as I said earlier, we see a lot of elderly population with getting fracture neck of femur. This lady survived after a fracture neck of femur with a hemiarthroplasty for 20 years. 20 years, this osteogenesis process is lasted, but unfortunately, she is very active, and even at the age of 90s, she was very independent, and this ball got eroded into the acetabulum, and we need to do something like a cage cup replacement. So because of the longevity of life nowadays, you need to think something like a total hip replacement, even for a fracture neck of femur, rather than straight away suggesting hemiarthroplasty. So this is the recent thinking. Now, not only the hip, you see a lot of patients with the shoulder problems, especially following the rotator cuff tear. The patients come with a severe arthritis and unable to lift the shoulder up. Elderly lady, very highly demanding. She said she wants to, lift her arm above her shoulder level. She wants to, comb her hair on her own and wash her clothes. So for necessity, we need to do a reverse shoulder arthroplasty. The concept is completely different. Use the ball on the glenoid and socket on the humerus. So this is why it's called a reverse shoulder arthroplasty. And this is another case. Sometimes with the fracture radial head in the past, we used to excise the head of the radius, and then these patients, they come late with instability of the elbow, or they have a severe pain in the elbow. So nowadays we tend to do a radial head replacement to get a stable elbow joint. So patients who have a 3-part, 4-part radial head fracture, you don't throw off the head and don't leave it without replacement. You tend to replace with a radial head. So this is the X-ray of the radial head, and good range of movements without any disability, and good supination, pronation as well. The most common in our country is most of the patients, they present very late. They don't come straight away with a bow leg. They have a typical waddling gait when they have a bilateral osteoarthritis of the knee. But patients always tend to use their own knee until the stage when they cannot walk, or they cannot put the next step forward. So this patient had obviously, because of the severe varus, she had a pathological fracture in the shaft of the upper tibia. Now, because of the severe osteoarthritis, bow leg, and we need to use a long stem with a total knee replacement. So she had a knee also replaced same time, and also address the fracture by putting a long stem. So patients should not come at this stage. You need to educate them to make sure they come at a very early stage. But our patients have become very demanding nowadays. They cannot, lead their life until it's completely arthritic and crippling, and they don't want to have a knee replaced at the crippling phase. So some patients' expectations are different. This patient, very active lady, she said she need to walk 10 to 15 kilometers a day. She runs a big shop, and she need to be very active. She drives a car on her own, and the middle compartment osteoarthritis, and with a middle compartment replacement, and to lead on a normal life. The biggest advantage of unicompartmental knee replacement is the patient can squat on the floor, or use Indian toilet without any problems like a total knee replacement. Nowadays, we've gone into the robotic joint replacement, and this is a big boon in arthroplasty, I would say, because the margin error has very much limited, and you don't commit any human errors, and it's a real-time intraoperative joint replacement, and you get a accurate component position, which will help in the long run, because the survival of process, when in the past we used to say 95% survival is for 20 years, but now I think with the advent of robotics, we are aiming for 98 to 99% line. So we do auto segmentation with the CT and use a J planner. We put all the data of the computer, and the computer designs and tell us what type of implant patient and what is their varus deformity, how much, and this is the long film showing how much the varus deformity, calculation beforehand, what size of implant which we need to use, and this is the peroperative picture. After putting in, you can see how nicely the component has been, very well fixed to the component, and also we do soft tissue balancing with the readings. So we get a good balanced knee, really the robotics has wonderfully worked, and this sort of imbalance can be very well corrected. So to get a normal medial lateral balancing, so patient gets a fantastic result with no residual deformity. So this is after the knee replacement with the good correction with no varus deformity. So this is a big boon, I would say, for the patients with the who has arthritis undergoing a robotic knee replacement. So these are the recent things happening in the joint replacement. So this just to put in a nutshell, what are things happening in each joints, just to enlighten everyone the current status of joint replacement. And nowadays, with all the major joints, I can assure 95 to 99% survival for a period of 23 years. So we are aiming for 100%. That means survival of all the joints for the rest of the life of the patient. So that is where we are moving in, and the technology definitely supports this. And I'm sure with the AI and robotics, the things is going to change a lot. So thank you everyone for the patient listening. Thank you.
Thank you, sir. Thank you very much for the excellent presentation, arthroplasty. So the next topic, update infertility diagnosis and treatment by Dr. ASHA Rao, Director of Rao Hospital in Coimbatore. She was a chairperson in endometriosis committee and the past president Coimbatore OBG Gynecology Society. She was the organizing chairperson Endo Insight 2020 International Endometriosis and Congress with FRCS, organized chairman in UO FRCS South Zone 2019 Coimbatore. She was the organizing chairperson in most of the national and international conferences. She published so many research papers, and she was the convener for the FRCS on endometriosis. She was the gold medalist from the President of India and from the University in Final MBBS. She delivered the first ICSI baby of Coimbatore in 1998 and first verification baby of Coimbatore in 2008. We welcome Dr. ASHA, madam. Over to Dr. ASHA. Yeah. Madam, kindly share your screen.
Yeah, thank you so much for those kind words. Let me share my screen. So much, my dear senior colleagues, and I thank Dr. Rajesh Babu and the entire team for having started such a wonderful course. I think it's a very good idea that you're trying to help young gynecologists to learn the secrets of infertility, because many of them, they may not be able to sacrifice 1 year and go and study somewhere. So this is a very good venture. And we at Rao Hospital have been practicing infertility for almost 40 years now. The first IVF baby of Coimbatore was born with us in 1976. And thereafter, we have had very many babies. And we also have endoscopy and women's care under one roof in our hospital. And recent advances in infertility. The first IVF baby herself is now more than 40 years old, and she has had a couple of children. And over the years, very many women are getting pregnant by IVF, because I think the incidence of infertility is getting more and more. And what are the causes of infertility? It could be female factor in 40%, male factor in 40%, and unexplained factor in another 20%. And according to WHO, infertility is now a disease. It's not just a condition, it is classified now as a disease because it causes so much mental agony to women. So if a couple is unable to conceive with 12 months of cohabitation and regular unprotected sex, it is called as infertility. So there are various causes of female and male infertility. And today the incidence is almost 17.5%. When we studied 40 years back, we said it was 10%. But today you can see it has reached an alarming level of 17.5%. And why is the infertility on the rise? I would say the age. Age is a very important factor because women have shifted the fertile years from 20s to late 30s. This is a very big change. And men are also getting older. There is habits of smoking, drugs, alcohol, stress of life. Both are working, and they hardly get to meet each other. And obesity, medical conditions, sedentary lifestyle, pollution, again a very important factor. Plastics are everywhere. And lifestyle diseases such as diabetes and hypertension also contribute to this. So if the couple is trying for 1 year and no pregnancy, you should definitely investigate. And if the lady is more than 35 years, one should investigate within 6 months. And you do the basic infertility workup. Ultrasound is very important. And today, blood test for ovarian reserve testing. It is called as AMH. Anti-Mullerian hormone plays a very big role. And we also do an antral follicle count by ultrasound. Because a girl child who is born with 1 to 2 million eggs at birth, by puberty, she only has 5 lakhs eggs. And over the next 20 years, these eggs start vanishing rapidly. So AMH decreases with age, and lower the AMH, lower is the fertility. So age is a very big factor today. And what is PCOS? PCOS is a very important cause of ovulatory dysfunction. It's also associated with obesity and type 2 diabetes, metabolic syndrome. Today you can see the whole generation is going lazy, food from Swiggy. Rarely anybody cooks at home. So obesity and diabetes are on the rise. So the PCOS is also on the rise. So it's very important for them to make lifestyle changes. And apart from ovulation induction, even IVF will be helpful sometime. So one side we have PCOS where the girl has enough eggs. On the other side, we have premature ovarian failure. That means a woman is going into menopause-like condition before the age of 40 years. So we are quite shocked when you see young girls with very poor ovarian reserve. They have less follicles by ultrasound and they also have less AMH. That means the chances of conceiving are less even when they are young. Even at the age of 28, 30, we see ladies with changes like that of premature ovarian failure. You can see here, the ovary, which should be like this, is empty in these girls. It could be autoimmune cause, metabolic, infection. Surgery is one more important reason. And for these women, you can cause ovarian rejuvenation. That's a fantastic concept that you can increase the egg numbers again. For this, PRP is very good. Platelet-rich plasma can be extracted from the patient's blood by various steps. And these platelets can be injected into the ovary to improve the ovarian reserve. So egg numbers may increase. So it can be used for poor ovarian reserve, premature ovarian failure, thin endometrium. It can also inject it into the endometrium to improve the endometrial thickness. So patients with recurrent implantation failure may be helped by PRP injection. Endoscopy plays a fantastic role for people with infertility. So hysterolaparoscopy is again an integral part of infertility workup. Earlier we used to do PCO drilling like this, puncture on the ovaries, but today we do less and less number of punctures because it may exhaust the ovaries. It is very good for helping women with fibroid uterus. In young age group also, almost 20 to 50% may have fibroids in the reproductive age group. So laparoscopy, you can see in various methods, it can help to remove the myoma and improve the pregnancy rate. Hysteroscopy also is useful for improving the fertility. Hysteroscopy is fantastic because there is no incision on the abdomen and patient may stay in the hospital just for 24 hours. Septate uterus can lead to multiple abortions, premature deliveries, and you can cut it very easily with the help of adhesions can be removed by laparoscopy. Endometriosis as another important factor which is on the rise. Endometriosis causes severe pain, dysmenorrhea, dyspareunia, dysuria, dyschezia, diffuse abdominal pain, and difficulty in conception. You have to try and diagnose it at adolescent stage itself early so that they do not land up with advanced stage like this. You can see very large chocolate cysts, adhesions, and this can be very easily removed by laparoscopy and it can improve the fertility. By ultrasound, you can see the big size chocolate cysts. This is a 3D ultrasound. Once it shows beautifully the chocolate cysts. And what about the male factor? Male factor is again, it's becoming a big problem over the years. When we studied 40 years back, we said 80 million, 80% motility. And today, very rarely you see men with 80 million, 80% motility. So the WHO definition itself says it is more than 15 million is adequate. And total sperm count can be around 39 million. And total motility can be above 40%. So gone is the definition of 80 million and 80% motility. We also do a DNA fragmentation test in the semen. And whenever there is a long count, we have to do a Y chromosome microdeletion. If somebody has a Y chromosome microdeletion, it will be transferred to the male child of this father. So one has to be very careful in because genetic condition will be transferred. So we may have to do a PGD or amniocentesis to rule out Y chromosome in the child. Varicocele used to be a very important reason for infertility, and we used to do a lot of varicocelectomies those years. But for the last 15, 20 years, we are doing less and less varicocelectomies because even with low sperm count, with the use of IVF ICSI, we are able to get a child. So the number of surgeries have come down. So the sperm count is less. You can do IUI like this, but success of IUI is only about 10%. So doing very many IUI is of no use. One may as well go in for IVF, the test tube baby techniques, where you collect the egg, get it out, mix with the sperms, make an embryo, keep in the incubator for 3 days, and transfer into the uterus. But today, the boon to men with less sperm count is ICSI, intracytoplasmic sperm injection, where a single sperm is injected into the ovum. For ICSI, you can see here, you require many oocytes, many sperms. But for ICSI, you require only one sperm. So even a man with very poor sperm count, even 0.5 million with a couple of active sperms can impregnate his wife and can have a baby of his own. Even 100% immotile sperm, previous failed IVF, and people who are azoospermic and have testicular sperms, all of them can have a child of their own by ICSI. And these embryos are studied in the incubator. And today, the incubator itself can tell you which is the fastest growing embryo. So there's something called as time-lapse imaging. There's a camera attached to the incubator where the petri dish is kept with the embryos, and that shows you very nicely how was the embryo at 19 hours, 34 hours, 36 hours, and which is the embryo that is dividing fast. So whichever is a healthy embryo, you can pick up that embryo and do the transfer. So the pregnancy rates will be higher. So time-lapse imaging is a very good advance these days. And we also have pre-implantation genetic analysis. We are always worried about defects in a baby. So if you do genetic diagnosis, it can be either PGS, that is pre-implantation genetic screening, or genetic diagnosis if there are specific diseases. And you can pick up the embryo which is healthy and then transfer. So the number of diseases in these couples will be much less. And yesterday there was a big article in the newspaper about pregnancies being put on ice. That is, girls are freezing their eggs into ice, liquid nitrogen, and by egg freezing, we can keep our eggs preserved So this young girl who wants to have a child only at 38, 40. Today, women are achievers. First of all, they have to have a good education, a good job, then maybe a good husband, and then the child if they want to have. There are many couples who say you for me and me for you. They may not even like to have a baby. But suddenly they may like to have a baby at the age of 38, 40 because that's the time they feel that the nest is empty. And by the time it's also empty. If we do egg freezing by the age of 25, 28, below the age of 30, the egg quality is very good. So this is when they can do the egg freezing. And then after 8 or 10 years, when they want to have a child and they have found the right partner, they can take the partner's sperms, have an embryo and become a mother at the age of 38, 40. So we need not force girls to have a baby at 18 or 20 like we used to have olden days. So pregnancy can be rescheduled at the time that the girl wants. Because we always tell our girls, so I got married at the age of 19 years. That was, I think, 2 months before pharmacology exam, and I had a baby at the age of 22. But today the girls are not willing for that. So social egg freezing becomes a very important need. In the metro cities, lots of girls are undergoing this procedure so that they can freeze their eggs and become a mother when they have completed many of their goals. So according to the very many papers, the egg survival is very good, something like 90 to 97%. And the fertilization rate is 71%. And the implantation rate also can be very good, like almost up to 41%. So egg freezing and later make an embryo has become a very popular technique. This is some gut microbiome. This is a very new concept. There are lots of bacteria in the gut, and some of them are harmful and some of them are useful. So when this ratio changes, it is called as dysbiosis. And because of this gut dysbiosis, change in the intestinal flora, there can be changes like PCOS, endometriosis, cervical cancer, endometrial cancer. All this can happen because of dysbiosis. And with the help of prebiotics, we can treat the dysbiosis. And many times, even the problem of infertility, recurrent implantation failure, PCOD can be treated with the help of diet and exercise by altering the dysbiosis. And what about third-party reproduction? It's very exciting. If the mother doesn't want to carry a baby, you can go for surrogacy. If the mother doesn't have the eggs, you can go for egg donation. So third-party reproduction has become very common today. And today, the government has enforced a lot of guidelines. There are ICMR guidelines, and now we also have very strict ART guidelines. The donor should not be more than 21, should not be less than 21 years and more than 35 years. Donor should not come asking for money. And you should check the donor's health for various diseases before you take them for egg donation. Even for the sperm donor, all these requirements have to be fulfilled. And surrogacy, again, government has become very strict, favoring more and more altruistic surrogacy. A relative can come and carry a baby for them. And it's amazing. 2 years that surrogacy was banned, lots of people are coming forward saying that I want surrogacy. Because some of them genuinely have a problem of not having a uterus or uterus being removed because of some diseases. Or even after delivery, one lady has lost a child somewhere else in a village. And because of heavy bleeding, the uterus also was removed. So such ladies, we can definitely help by surrogacy. So strict screening is very important. So science is going in a different way where you can have perhaps a designer baby. In future, you can choose perhaps the color of the baby's eyes, color of baby's hair. You want to have a tall baby, dark baby. So many genetic modulations may happen. So it is, I'm very glad that we are able to start this course at Rao Hospital and train lots of young people in the techniques of infertility. And thank you, dear IMA dignitaries, for having started this course. Thank you for the opportunity.
Thank you very much, madam. That is an excellent presentation, madam, covering all these sessions. Then we can have the question. Yes. We move on to the next session of current trends in the regenerative medicine. by Dr. Ravi, is an senior orthopedic consultant, director of the Maruti Hospital, Trichy. She studied MBBS from MBBS and diploma in orthopedics from Tanjavur Medical College and MS Ortho from Madras Medical College. She received so many awards from the government of India, and he treated the world first FDA approved allogenic stem cell therapy for critical limb ischemia and osteoarthritis. He treated the world first class with combination of 3D bioprint with bone marrow aspiration and concentration for the diabetic ulcer. He established a ISO standard GLP facility for training in regenerative medicine with plasma, platelet-rich plasma, stem cells, and NK cells at Trichy. He has given various presentations and published various articles in the national and international conferences and journals. We welcome Dr. Ravi, sir. Over to Dr. Ravi.
Thank you, sir. Be thankful to the AMS team, the energetic chairman, Dr. Rajesh, Dr. Jayaraman, sir, and Dr. Radha Sindil, sir, for giving this opportunity, and our IMA president, Dr. Abul Hassan, for supporting us in all these endeavors. So actually, this regenerative medicine is slowly picking up, and you can see that many doctors are getting interest in the field of regenerative medicine. So that is because our treatment modality in allopathy with substitutive treatment as well as symptomatic treatment is now coming to an end. So we want to move from symptomatic treatment and substitution treatment to curative treatment. So many people know that there is something called the stem cell therapy, gene therapy, and they think that still it is in the research mode. But the fact is, stem cell therapy is already approved in India. Many people don't realize that stem cell therapy is already approved in India, and what we think as future is already in the past. So the first approval for stem cell therapy for Burgess disease came in the year 2017. Now we are in 2024. So already 7 years before the first approval had come. And all these many achievements are because of many legends. Most of them in the field of regenerative medicine are from Tamil Nadu. So all of us know about Dr. Surendran, sir, who is the retired HOD surgical gastroenterologist Stanley. He started the first stem cell lab in a state medical college in the late 2008, 2009. And he handed it over to Dr. Rosie Vanilla and Dr. Secunda, so who is now looking after the lab. And the lab has grown from a small facility to now a GMP government DCJ approved facility where stem cells are produced, and they have got the approval for the liver disease treatment, both acute as well as chronic liver disease treatment. So they are in the stage of approval for the phase 1 trial. But there are certain other diseases where the phases of human trial have been completed and the product has come out. And that is because one more legend from Chennai is our Dr. Rajkumar. So he was the HOD of the vascular surgery department at Chennai, and he was the principal investigator for the stem cell therapy for critical limb ischemia, particularly where there was no option, where the artery was blocked at multiple points, and where the endovascular procedures have already failed. So he was the first principal investigator, and that product is now readily available in the market. So if you can see, this is the product which is called as the Regina SIP. This is from the Cipla, but this contains 150 to 200 million mesenchymal stem cells taken from young adult. So this treatment has been approved since 2017, and the product came out in 2020. So the Burgess disease was the first approval. Second approval was CLI and PAD for diabetic ulcers. We are seeing many cases of amputation due to ischemic pathology affecting the blood vessels, atherosclerotic obstruction. And as I said, when the endovascular procedures fail, then stem cell therapy can create new blood vessel formation, new angiogenesis and new vasculogenesis. So Dr. Rajkumar is again one more legend who contributed to the advent of the stem cell therapy. And Dr. Cherian, all of us know, is a famous cardiac surgeon. He has completed the animal study, and for cardiac, for particularly cardiomyopathy, so the human trial will be going on. And Dr. Namita Madam, she was the director of the Ophthalmology Center, the regional eye center at Egmore, where they have been doing innumerable cases of limbal stem cell therapy. So limbal stem cell therapy is a very popular surgery for patients who are totally blind, corneal blindness, one of the very common cause for blindness. And because there are not many donors, now they have already doing this limbal stem cell therapy for more than 20 years in every big tertiary care eye hospital like Shankar Nethralaya, Aravind Eye Hospital, Narayan Nethralaya, and other. So with all this, we have, as I said, we are already entered into the arena of the regenerative medicine. And when we say regenerative medicine, it is because of we use the products which are available in the body, whether they are the cells or whether they are the growth factors present in the plasma. So Dr. ASHA R Madam already talked about the platelet-rich plasma, and a lot of people have started using this. And I am just giving the definition as using our own body's products like the cells or the healing factors, which can reverse the debilitating effects of multiple pathologies, not only musculoskeletal, but other pathologies too. So as I said, these are the approved products I'm just putting out. There are 7 approved stem cell therapy products in India, and India is the only country where there are this many approved stem cell therapies. In Korea, there are 2 or 3. In Japan, there are again 2 or 3. But India has got 7 products which are approved. Apart from that, gene therapy, which was approved by the US FDA, is being used in India for children with spinal muscular atrophy. Similarly, CAR T cell therapy is one of the very prominent immune therapies for cancer. So already we know there are surgery, chemotherapy, radiotherapy form the 3 pillars of cancer treatment. But the 4th pillar is immunotherapy. And in immunotherapy, you have got biological agents as well as this form of CAR T cell therapy, where the T cell of the patient is taken and it is manipulated, genetically manipulated, and it is made to attack the cancer cell. And in India, again, 2023 October, 1 CAR T cell therapy is already approved. So these are all futuristic treatments which are already available in India. So this is again some of the stem cell condition medium products for hair regeneration, skin regeneration, and under eye dark circles. Similarly, there is one more company called Regrow Biosciences, where if we take a biopsy of the bone and send the biopsy to the Regrow company, they will grow 48 million cells, and then they will send it back to us for cases of osteoradionecrosis or avascular necrosis. Similarly, cartilage can also be grown, and particularly urethral stricture, which is very common post-trauma as well as repeated infections. You can take a biopsy from the mouth, from the buccal mucosa. You send the biopsy to the company, they will grow 48 million cells and send it back to you, which you can inject into the stricture, which is less than 4 centimeters. So these are some of the products which are already available in India, and this is the approval letters, because many people could not believe that these are approved in India. That is why I posted these approval letters given by the FDA, Indian FDA. Again, as I said, in Japan, Europe, and South Korea also, there are treatments approved, but we are leading. So this is STEM 1 is actually what you see. This is the product STEM 1, and this contains 25 million mesenchymal stem cells for osteoarthritis. As Dr. Rex said, in very severe cases, grade 4, where there is a deformity, where there is a total destruction of the joint, the surgery is the gold standard. But there are a lot of people who are in grade 2 and grade 3, who don't need such big surgeries and who want to try conservative treatment before trying the ultimate treatment of joint replacement. So if people want to avoid the joint replacement for grade 2 and grade 3, then this treatment, which is allogenic, is available in India since 2022. Already, orthopedic surgeons, we are using the platelet-rich plasma and the bone marrow autologous for many of the musculoskeletal conditions. But this is a good addition to the armamentarium of the orthopedicians, and they have proved at least 1 year of pain and stiffness reduction, and it is the only available treatment that maintains the cartilage quality and volume for over 1 year, and the minimal side effects compared to what is normally seen in the other treatments. So these stem cells are taken from young adult. So here you can see it is being taken from one person and from the iliac crest, and from what is obtained from 3 people is pooled into it can be cultured. It can be cultured into 300 or 3,000 or even 1 million doses. What is taken from 3 persons can be converted into 1 million doses by culturing. So by doing this in a big lab, like an industry, which is available in Manipal University by the name Stemputics. So that they have got a very good lab at Manipal where they culture these stem cells, and these products are available according to the approval given by the DCGI. So some of the cases of osteoarthritis, which we had done even before we got this product using autologous patients who own bone marrow stem cells, you can see that the narrowed joint space can be increased. There can be growth of the cartilage, and particularly in the age group of 55 to 60, 50 to 60, you can see in osteoarthritis in stage 2, stage 3, we can regenerate the cartilage. And how long does that effect last? So again, this is another case where you can see before and after. You can see the increase in the joint cartilage space, as well as the improval of this quality of the articular surface improvement. And as I said, how long the effect lasts? Up to 4 to 5 years, you can see the improvement with a single dose. Here is a case of 54-year-old female who had osteoarthritis stage 3, where after injection up to 48 months, 4 years, she had very good relief, and there was initially increase in the cartilage height, and after 4 years, again, it has slowly started to decrease, and she is ready for a booster dose. So people who do not want to have a second to undergo surgery can have booster doses and continue their improvement for a few more years. And it is not only cartilage. When we say about osteoarthritis, it is not only the cartilage, but the other structures like the meniscus, the cruciate ligaments, the other soft tissues, which are also affected. So here you can see the ACL tear, partial tear, which is healing after the injection of the PRP, platelet-rich plasma, into the joint. And we can assess the quality of the improved structure, whether it is the cartilage or whether it is the tendon. The MRI can show the improvement in the quality of the cartilage. This is called a histogram, where a shift to the left indicates after treatment that the cartilage has not only reformed, but the cartilage strength has improved from what it was before. So again, here also you can see one more case of ACL tear, partial ACL tear, where it has regenerated, and it can be seen that not only the quantity but the quality of the ligament has also improved. So nowadays we have got a lot of these techniques using the MRI. Particularly, the MRI has got software which can show what is going on inside the body. So this is again a meniscal pathology, a meniscal tear, which has completely healed after injection of PRP within 6 months. So as Dr. ASHA R madam said, there are a lot of people now today using the platelet-rich plasma. So the dermatologists are using it for hair and skin regeneration. orthopedics, we are using sports physician, plastic surgeons are using for skin augmentation, diabetologists and vascular surgeons are using to avoid the amputation by creating angiogenesis. Gynecologists are using it for endometrial and ovary regeneration. And again, what is applicable for the ovary is also applicable for the testicular regeneration, and many of the andrologists are trying that. And ophthalmologists, as I said, they are the leading specialists who have in the field of stem cell therapy, where they have done for more than 20 years, they have regenerated cornea. And today in Aravind Eye Hospital, they are injecting patients who own PRP for retina regeneration. First time in India, they are doing retinal regeneration in cases of macular hole, which is like a diabetic ulcer, which recurs. So there are a lot of these specialists. Anesthetists, pain physicians are using it for degenerative musculoskeletal conditions, and dental surgeons are using it for many dental indications. Oral submucous fibrosis is one condition where people take Panparak and then they are not able to open the mouth. It goes for trismus, and then we have treated some of the cases of oral submucous fibrosis. So this is the one more latest addition is 3D printing. So this is a 3D printer which is approved in India to be used by, this is from a South Korean company called Rokit Healthcare. So this is a tabletop 3D printer which can be taken inside the operation theater. So once a patient has got a diabetic ulcer or any ulcer which is non-healing for a long time, we have to take a picture with a 3D camera provided with this printer. You take the picture and by Bluetooth, you send the picture to the 3D printer. Then you take the patient's fat from liposuction. You do liposuction and takes patient's own body fat and then use it as in one of the bio inks. So here you can see two cartridges. This red and blue. These are two cartridges which are found in the 3D printer. And in one of the cartridges, this patient's own fat stem cells are stored. And in the other, the company itself gives a fibrin glue. So when the size and shape of the ulcer is detected by the camera and which is passed on to the printer, within 30 minutes, using these two bio inks, the same size, shape and size of ulcer, you can get this is the 3D printed material, which within 30 minutes, the printer is able to print this and which can be kept over the ulcer, same size, same shape, it can be kept over the ulcer and then a dressing is done and then the healing happens within 30 days. So as I said, one more recent advance is the CAR T cell therapy, where as I said, for cancers, particularly in leukemia and lymphoma, what they are doing is they are taking the T cell from the patient and then they are transfecting it with the virus, and then this genetic engineering is done so that the T cells become very responsive to the particular cancer antigen, and then they can kill all the cancer cells. So in leukemia, particularly B-cell leukemia, they have achieved phenomenal success. And now they are moving on to solid tumors also. Gene therapy, as all of you know, is already approved throughout the world. And in India also, a few cases of spinal muscular atrophy have been treated by this gene therapy. Today, it is only the Novartis which has got this gene therapy for the particular condition. But already Indian doctors in the Narayana Nethralaya as well as in the LV Prasad Institute in Hyderabad, they are already started gene therapy trials for some of the ophthalmic conditions affected by genetic diseases. And one more is the genetic disease of osteogenesis imperfecta, which was treated at CMC Vellore with stem cell therapy. So this was just a clinical trial, phase 1 clinical trial, which is a multi-center trial also done at Sweden and in CMC Vellore, where when the child is inside the womb, 1 dose of stem cell is injected into the umbilical vein. And after the child is born, 3 or 4 doses of stem cells are injected into the long bone. And they have got a follow-up of 4 years. And within these 4 years, the children have not developed fractures. You know, osteogenesis imperfecta, even when the child is handled, the bones, long bones go for fracture, and CMC Vellore has successfully conducted this clinical trial. So coming to the conclusion, every tissue in our body can be regenerated. So as I said, we have come out of the era of symptomatic treatment and substitutive treatment. Now we have come to regenerative treatment. So we can regenerate the hair, we can regenerate the skin, we can regenerate the endometrium. Dr. ASHA R had already talked about that. And then we can just regenerate blood vessels. As I said, this is the when case of Burgess disease, where there is no blood flow below the ankle, after injection, you can see the collaterals. Then neural regeneration in cases of cerebral palsy, and then other tissues also. I'll be showing some of this. This is skin regeneration, post-irradiation skin fibrosis. In oral cancer, when they give the radiation, the skin also undergoes fibrosis. And here you can see after injection of the patient's own bone marrow stem cells, the skin has come back to its normal suppleness. And this is gluteus medius regeneration, which is muscle regeneration. As I said, every tissue in our body can be regenerated. And this is one more thing which I wanted to show is the melanocyte regeneration in cases of vitiligo. So where according to the protocol which is devised by the AIIMS Delhi Department of Dermatology, we have taken the melanocytes from the patient's own hair follicle. You can take 20 to 30 hair follicles from the back of the head, and then you can separate the melanocytes and stem cells from the hair follicles, and then we can inject it, and you can see that the vitiligo area has been completely getting repigmented. So you can see even the color and the texture of the skin is becoming very good. So this field of regenerative medicine is evolving, and it is I'm very happy that IMA is interested in imparting this knowledge by introducing this course of Regima. This is a fellowship course in regenerative medicine, which we will be starting at Morthy Hospital. And the same structure, the structure is the same for all the IMA, AMS courses. And so Dr. Rajesh Babu can say about the general structure of these courses. Thank you, sir. Thank you for the opportunity.
Thank you very much, sir. Dr. Rajesh Babu, sir, for your comments.
Yes, we are going to start the courses, and already people started registering for the courses also. And for the registration, we have got the applications along with the brochure will be attached, and those who are interested can do the registration. That is the process, and I will send to the course directors also the applications form. Already I sent them the application form along with the brochure, so that they can circulate. And once any queries comes and once people started joining, we will start the course from October. And each of the course director, Dr. Rex and Dr. ASHA R madam and Dr. Ravi, you can decide the dates of starting of the courses in the month of October. And then once we have got the number of people, enough number of people, you can do it. At the same time, I request all the course directors to give the timetable of how they are going to conduct the courses for the whole year, for the period, which is suggested by the IMA AMS headquarters. So I request, there are a lot of questions which was put by Sundaramurthy sir, that we will come one by one. Before that, regarding the courses, I like to have opinion from each of the course directors. Now I invite Dr. Rex sir to tell briefly about the course. He has given the wide view about the arthroplasty and all those things, and how they are going to take the class, and how many classes they will be conducting per month. Like that, they can split up roughly, they can tell now, and finally they can come out with a concrete protocols. Rex sir.
Yes, sir. Proceed. Proceed, sir.
Monthly, we are planning to conduct at least 2 weekends there. Maybe Friday, Saturday, Sunday depending on the convenience of the students. We will conduct theory classes will be there for at least say 4 hours there. And then we have a practical module. They can come to the theater. They will be every day afternoon they will be with us in theater. And the morning they will be with us in the outpatient department. And we will conduct an exam at the end of every month. And we have a module every month. What are the chapters which will cover in each aspect, like starting from anatomy to the biomechanics, and then the physiological part, and every aspect we will cover. We have a module of 10 modules there. 10 modules with a question and answer session. We'll have a MCQs at the end of every 3 months. And then we have a complete assessment with a written exam. And also we'll have a practical proper viva for a proper clinical examination, and then proper presentation by the candidate at the end of 1 year. Like a typical MS Ortho exam, we will conduct for a whole day. And then we'll assess the candidate and give the certificate. But the only thing is, they need to have some flexibility in the hours of work. And we are here from morning 8 to late evenings. So from our side, there is not a problem at all. Only from the candidate side, they need to spend at least quite a number of time in the hospital, and also maybe for the theoretical aspect, they can come on the Zoom meet. We can on the Zoom platform, we can teach them the theoretical aspect, but they need to spend a good amount of time in the theater and also to be with us in the outpatient department. So that is what we are looking for. And at least monthly, 5 days, they need to spare with us. So that is what we are thinking, sir.
Sir, where is the course conducted, sir? Location of your hospital, and how far it is from the railway station and airport? You please tell about that, sir.
The location of our hospital is only 3 kilometers away from the railway station, and from the airport maybe 10 to 12 kilometers. And we are own. We don't have any. We can help them out in any accommodation nearby problem, and definitely we are where they want.
Any questions
And
from the participants?
Maximum 10 students per year, sir.
Yes, sir. That's what we are also planning. And any
Yes,
questions from the participants who are interested in arthroplasty, please, you can please ask the Professor Rex, sir.
Only thing is they need to complete the module then and there. That is what is very important. They cannot accumulate and do it at the last minute, because that is important.
Sir, since you are already conducting the DNB courses also, I think you will be conducting a very strict exam and all those things like that. I think so.
Yes, sir.
It will be a Paka training, I think.
The candidate passing here must be
so
they perform the arthroplasty.
Yeah, that's what
we aim for.
Yes, sir. Thank you so much. Thank you so much.
Sir, Dr. Rajesh Babu, sir, to the Dr. Rex and Dr. Ravi, is the trial of stem cell therapy is alternative to the arthroplasty?
This question goes to Ravi, actually.
No, both.
I don't have any answer for this.
Sir, actually, it is only in stage 2 and 3. So stem cell therapy is not for stage 4, where already the destruction is very severe, and already where as Dr. Rex showed, when the deformity, there is an acceptable deformity up to 8 degrees is acceptable, whereas, but when the deformity is beyond the redemption, and when the destruction is also very severe with the subluxation and instability, there are certain factors which determine that only the gold standard treatment of joint replacement is going to help the patient, and stem cell therapy cannot help the patient. So it is only in stages 2 and 3 where they want to postpone the surgery for some more time. And patients who are very lean, patients who have a normal BMI and who regularly exercise, they can probably have a very long period of relief with stem cell therapy, and they can avoid going to the stage 4. So it's not an alternate. It is one more option before joint replacement.
Any age limit for arthroplasty, sir? Dr. X, sir?
No, so that is what I was telling you. The youngest age I have done is 9 years and 12 years in India. These patients are juvenile rheumatoid arthritis, came in a wheelchair, completely destroyed joint, not able to attend the school. So there is no other go other than the quality of life is important. So that is why we did at a very young age. The oldest surgical replacement was 109 years, sir. But he was very active and he lived up to 116. So it's only the physiological age that matters.
Any success rate varies according to the age, sir? Success rate of arthroplasty varies in relation to the age of the surgery. Next, sir.
Age doesn't matter, sir, for the success, sir. But what I'm thinking is you need to always counsel the patient for the better results. Once you explain, you should match the expectation of the patient. That is very important. Because patients who are very happy to walk inside the house, even at a very elderly age, they are very happy. Similarly, a patient very young, he'll be very unhappy if he can walk only at home, not able to go out. So you need to match the expectation of what the patient wants. If you really explain the realistic expectation of what we can expect at the end of surgery, probably it doesn't matter, age doesn't matter.
Okay, sir, thank you. This is the question for Dr. ASHA Rao, madam. Do you program IVF for twins as per the patient wish?
Pardon me, it's not clear.
Do you program IVF for twins as per the patient wish?
Program IVF for twins?
Yeah. If the patient wishes to have a twins, is it possible to program?
In general, in IVF, you can transfer 1 or 2 embryos. We generally do not transfer more than 2 embryos. So that way, when you transfer 2 embryos, it can result in twins. But we never program for 2 embryos.
We never program.
Yeah, because as much as possible, a single baby is better grown in the mother's uterus. Chance of premature delivery are also less. But the implantation success is better if you transfer 2 embryos. At least one may implant. So that way we are putting 2 embryos, but we never guarantee 2 babies.
Okay, madam. What are the common?
Sometimes you may transfer 1 embryo can divide and become twins also. So, but you cannot plan it.
Yes, sir.
One question to madam.
Yeah, telling sir.
Madam, I'm Dr. Jalil, madam. Excellent presentation.
Good evening, Dr. Jalil.
Good evening. This is regarding egg freezing. Like that, you have a social sperm freezing also. What is the legality of this procedure, madam?
So far, nobody has objected. There are no objections from the government so far.
Is it due to legal issue, madam?
No law has come to oppose this so far. Government brought in a lot of rules and regulations, but there is no regulation against egg freezing.
Okay, madam. Commonly, just you can come out with what are all the common legal issues you come across so far?
Legal issues in IVF?
Yeah.
Legal issues in IVF is age factor. Sometimes women want to have a baby beyond 50. That is not allowed. If the man's age is more than 55, it's not allowed. There are couples coming and crying, even when the woman is 50 and man is 55, they're still crying for a baby. So that is not allowed by the government now. And we see issues sometimes in egg donation and sperm donation. Sometimes the sister comes and gives eggs to the sister, and later there may be a problem saying that this is my baby, I want to take my baby with me. You know, this sort of things can happen.
Okay, madam. Does cloning procedure come under regenerative medicine?
Cloning is not done in India so far. So there are no thoughts or regulations about that.
Oh. Age limit
Nobody's
for
doing
regenerative medicine
nobody's
therapy?
doing cloning in India. So
Okay.
it's out of question.
Okay,
Now, the
madam.
problem is all revolving around surrogacy. After all the actors have had surrogate babies, every common man thinks that they just come and say, my implantation failed twice, I want to do surrogacy. They do not realize how difficult it is, you know, how much money they have to spend because they have to give money to the surrogate.
Is it legally authorized, madam? Surrogacy is legally authorized in India?
Surrogacy is legally authorized. They can pay for the surrogate's travel and accommodation. Or we also prefer the sister or relative to come and do the surrogacy. It is legally allowed now.
Regarding the social egg freezing, madam, how long we can keep it, madam? The maximum?
Maximum is 10 years.
Okay.
So there are a few questions.
Yes, sir. Yes, sir. Dr. Ravi, sir.
Can stem cell treatment be done for macular edema? And can stem cell treatment can be done for macular degeneration of retina if done where? அதுக்கு வந்து Dr. Sasi I Salem regeneration, he has given an answer. Yes, sir, for macular edema, it can be done.
Actually, in the eye hospital, Dr. Naresh Babu is already doing for macular hole. So, and he has already published. So they are already using autologous platelet-rich plasma injection after doing the procedure called internal limiting membrane peeling. So already the regenerative treatments for retina is being done at Arvind Eye Hospital and some more hospitals in India.
Dr. Sasi, you can throw light on that.
Any age limit for regenerative medicine therapy?
Sir, actually, there is no age limit.
Hi, sir.
Yeah,
Thanks for giving me an opportunity, sir. I'm Dr. Sashi from Salem, ophthalmologist. I've been doing stem cell therapy thanks to Dr. Ravi, sir. He's my mentor and guru, and with him I've learned, and I've been doing for more than 2 years now. Yes, I'm getting pretty good results for a lot of conditions from ranging from macular edema, macular degeneration, macular dystrophies, retinitis pigmentosa, optic atrophies, partial optic atrophies, so on and so forth. And I have testimonials of patients who have done it and who have got benefited out of it as well. And it is working well in our hands.
Sir, Ravi, sir.
Yes.
Where is your center? And you tell briefly about your center and the location and all those things.
Yes, sir. We are conducting this program at Maruti Hospital, which is very close to both the central bus stand as well as the railway station, hardly 2 kilometers from the bus stand and the railway station, and 10 kilometers from the airport. Trichy has got an airport too. So people even outside from Tamil Nadu, if they want to learn, so they can come. And we are also trying to conduct as 2 theory and 2 practical classes per month. So it will be 12 modules. And as Dr. Rex said, we will complete the module and do the exam and then only proceed for the next module. We will not allow the students to collect it and then do it finally. So then and there it will be done. And finally, there will be one exam at the end of 1 year. Following that, we will be giving the fellowship certificate.
Madam ASHA R, madam, you can briefly tell about your center location and the sessions, how you are going to do, all these things you can tell briefly, madam.
Madam. Madam, ಇಲ್ಲ sir, madam ಇಲ್ಲ. Sir, Ravi sir, one more question to you. Ravi sir.
Yes, sir. Sir.
Role of stem cell therapy in poisoning cases.
Poisoning, we have not done, sir. Actually, there are. I don't have read about any uses in poisoning. Probably acute renal failure, acute pulmonary failure, they have tried. It is not for it is not only for poisoning, but any acute renal as well as acute lung ARDS. There have been trials going on, but there is no approved treatment till today for any of these things which I mentioned. So I already showed certain diseases when only those diseases are approved for stem cell therapy. Others are all only in the trial mode.
Neurological degenerative diseases, any role, sir? Stem cell therapy?
Actually, in Japan and Korea for Parkinsonism, there is already stem cell therapy available. So it is 5 doses. Each dose is 200 million and 50 million is given intrathecal and 150 million is given intravenous every month for 5 months. And that is for Parkinsonism, and they have shown recovery results where it was not, the drugs have failed. But in India, it is yet to be approved. But in India, then recently, 1 month back, they had come out with a rule which says that you can import such treatments from foreign countries if they are available without any extra clinical trial in India. So probably what is available in Japan, with the permission of the government, we can do it in India.
Okay, sir. Any absolute contraindication to the stem cell therapy? What are all the absolute contraindications?
Pregnancy and cancer are 2 absolute contraindications, like any drug. So whenever we prescribe any drug, we try to see what is the effect on the pregnancy, on the fetus, as well as particularly in cancer. So the same way, there are stem cells are contraindicated during pregnancy and during cancer. But as I said, there are certain indications, genetic diseases, which are given during the stages of pregnancy. As I showed in CMC Vellore has done for case intrauterine, as well as immediately after birth, the stem cell has been given to the child.
Madam ASHA R, madam, you please tell
yes,
about the.
I'm here. I'm here.
You tell about your location and your plan of action. The module.
We are in our hospital is in RS-puram. We are centrally located, and I plan on doing 2 days, twice a month. That is a half-day practicals and a half-day theory. And I do not like to do Saturday, Sunday. Is Tuesday, Wednesday okay?
Madam, everything you have to tell to your students and they will follow as per your wish, madam.
Okay, fine. Yeah, I would prefer, I think beginning of the week is good, Tuesday, Wednesday. Monday always gets a little more busy. So Tuesday, Wednesday, we'll do half-day theory and half-day practicals. Because we have enough staff who are used to teaching the MGR University courses. So we can take according to the syllabus that you have already written. No problem at all. And there is also endoscopy going on at the same time. IVF also is going on, so they can see both. And if you're interested, we can allow them to assist sometimes in the endoscopy theater also. Hysteroscopy also is very much interesting to the young doctors.
Thank you, madam. There was a request from iPhone. iPhone person is there. You can ask your doubts. iPhone. Can monthly physical class be avoided for practicing surgeon in Delhi?
Sir, course fee is different from course to course, is it?
Madam, only for diabetic retinopathy workshop course only it is 59,000, madam. The rest of the courses are 30,000 only, madam. That is because the diabetic retinopathy, the Dr. Kosalram was insisting that they will be paying the money 50,000, 59,000. We will do it, sir. That's why we fixed like that. The rest of the courses all are 30,000 only, madam. In the first
So
flight,
something
the
that-
laparoscopic course, we have put it as 50,000 and the response was very less, and that's why we reduced it to 30,000, madam, actually.
I
And
agree with
converted
you.
all the 4 courses to 30,000, madam. That's all.
Maybe you can see 1 year and then we can decide.
Ah, yes, madam.
There
These are
is a
all.
question, yes, sir. There is a question to Dr.
Hello.
Ravi. Lumbar degeneration with radiculopathy, is there stem cell therapy done now?
Sir, actually, it is not for the disc. If it is a facetal joint, if the facets are deranged and sacroiliac arthritis, certain indications of low backache. Low backache due to certain pathologies we are already doing with the platelet-rich plasma. But for a disc, we are not doing it. But there are pain physicians who are already doing intradiscal injections. And I have seen some of the MRI where they have shown the regeneration of the disc. In USA, there is a company called Disc Genics. So they are in phase 3 trial. Once they complete the phase 3 trial, they have taken stem cells from the disc which is removed from the patients during spine surgery. So they take the bits of the disc and then they have taken stem cells from those discs and then they have made a product. And it will soon be available in USA on approved. And as I said, if it is approved in one country, there is a possibility that we can import some of those stem cells in our country, and also we can use it with approval. But today there is no approved stem cell therapy for disc, but PRP therapy is being done by many pain physicians and musculoskeletal people in India.
Nice, sir. Any age restriction for stem cell therapy, sir?
No, sir. There is actually, it is as degenerative diseases are always old age diseases. So we have done for a patient with Alzheimer's disease who was 92 years old. He was a relative of our own doctor. So we had imported stem cells and then we had done that. So, and we found improvement. The person lived up to 104 years. But that is a very rare case. But it is not very neurological cases. It is very difficult because as we all of us know that the regeneration capacity of the brain is not equal to the regeneration capacity of skin or a liver or a kidney or a heart. So though there is some possibility, but it is very, very limited.
Okay, sir.
Can stem cell therapy helpful in paraplegia?
Sir, paraplegia, if it is not totally cut off and in very early stages, the possibility of recovery is there. And if it is combined with the decompression, when you do the decompression and when you see that the cord is not totally cut off, then we can add, it is actually an addition to the surgery. So healing, when we are only helping in the healing, it reduces the edema, it reduces the inflammation, just like steroids. Like how we add steroids before surgery or during surgery or after surgery to reduce the edema. Same way that edema reduction happens with the stem cells, whereas steroids will not promote regeneration, but platelet-rich plasma and stem cells will promote regeneration. So it can be, it has been combined with surgery by many neurosurgeons.
Sir, there is a question from an iPhone person. I don't know the name of the person. If the person is available, you can call and ask, sir.
Yes, sir.
Sir,
I'm
you
doctor.
are doctor?
I'm Dr. Anuj Dhingra I'm practicing orthopedic surgeon in Faridabad.
Yes, sir.
So, yeah, I know because monthly it not be possible for me to come to Trichy. So is it possible if I don't attend like...
Sir, instead what you can do is, sir, initially we will start the course on one particular day and Dr. Ravi will be telling everything about how they are going to conduct the course. And subsequently, practical classes you can club 2 or 3 days which are helpful for you. You can discuss with them in person and they are through online, and then you can decide about that how to go about it. Because hands-on course you can take in at least initially you take once, and after 6 months like that you can take once more. In between you can take online courses.
Yes,
Yeah,
sir.
sure, sir.
So that you will be able to learn and complete your process, sir. That's what.
Yeah, that
That
will
is
be
the
good,
main
sir.
aim of doing it, sir. So if you are interested, you can join in that course as per the advice and you can proceed, sir. That's
Thank you,
what.
sir.
So
Yeah.
what is your phone number, sir?
Sir, 9810
9810
200
200
260.
Your name, sir?
Dr. Anuj Dingra,
Anuj. You are practicing in
Faridabad, sir, near Delhi.
orthopedic surgeon, huh?
Yes, sir.
Okay, sir. Welcome, sir. Thank you.
Welcome. Thank you, sir.
Any other questions? So people can join straight away as per the instructions, and if you have any doubts, you can call. You can tell everything has been put up in the brochure. And regarding the regenerative medicine, we will be coming out with the brochure within a day or two, and that also will be published, and the course will be started from October onwards. And I request all the course directors, please frame your protocols, what is your plan of action and all those things, as our president has requested to put a booklet like that for all the courses. We will create a booklet like that, and then we will arrange the whole thing. That is the main thing. It will be good for all the participants.
Will do it, sir.
So any other questions are there, Sendil Kumar? We can go ahead, or we can close the session, I think.
We can close, sir.
Mm.
So thank you very much, sir. Dr. Rex and
Rex, sir, you want to tell anything?
And Ravi,
No,
sir.
I'm fine. I'm very clear. I'm very amused by the work of Dr. Ravi. He's doing a wonderful work on the regenerative medicine, and
Thank you, sir. Thank you.
that's really very nice to hear so many new things, new developments, which we are not aware of.
Thank you. Thank
Very
you.
nice. Keep the good
Sir,
work.
So actually, we have a conference next month, September 18-19, where I am inviting all our doctors. So it will be a regenerative medicine conference, and there will be talk by orthopedic surgeon, gynecologists, dermatologists, urologists, and other specialists also. And we are going to have two programs. One is organ donation. We are going to include stem cell donation. So I am inviting Dr. Rajesh Babu sir for that conference, where we will create awareness about stem cell donation. So not many people don't know how to give stem cell donation. So we will be conducting a camp during that conference, and I invite all of you, particularly sir, Dr. Suresh Babu sir will be definitely there, I know. So we are adding one more to organ donation. So it is a news to many people that from cadaver, after taking all the organs, you take the kidney, lung, liver, everything, the bone marrow can be taken up to 24 hours after death, because the bone marrow stem cells always live under hypoxia. So they are living under hypoxia. And so after retrieving all the organs, it is possible to take the aspirate from the bone marrow, the stem cells, and then preserve them, like how they do the cornea. So they take the eye and then they preserve the cornea, use it for the, then dissect it, take the cells from the eye, and then they are using it. So the same way, the bone marrow can also be taken from the cadaver, and all these things we will be discussing, sir. Dr. Rajesh Babu sir, it is going to be an exciting possibility. I welcome you, sir, using this opportunity.
Very great.
Dr. Sasi, sir.
Sir, one word, sir. Just want to know when is that conference, sir? And
18 to
where?
19 September in Trichy. I will say
September.
September 18 and 19, sir. It is on
Yes, sir.
Wednesday and Thursday, I think.
Yes,
Okay,
sir.
okay.
We have also
Sir,
one basic life support, that Jai Jeevan scheme also we are doing for the college students. So I am also inviting our President, Dr. Abul Hassan also, because this program will be guided by the principles of IMA.
sir, another thing to add on, sir. Also, an interview of Dr. Ravi and me questioning him is there on YouTube, which we'll share. Which will cover, it's an 1 hour interview of the basics of, from basics to the detailed part of stem cell therapy and So that will be helpful for a lot of people.
Yeah, it is a very, very big 1 hour interview, sir. It is very difficult for people to sit and listen for 1 hour. So that's why we have broken up and made it is 1 year course.
Sasi sir, you can send that YouTube link to me so that we will circulate among all the people, sir. Even in IMA Tamil Nadu also we will do it, sir.
Definitely, sir.
You may be having my number, I think. That you can...
Yes, sir.
You please send it to my number, sir. The YouTube link. Then we will
Sure,
see.
sure, sir.
Yes, sir. Thank you so much, sir. Yes, Sendil sir.
Sir, yes, sir. The Jayaraman sir, for vote of thanks.
Yes, sir. Can you hear my voice, sir?
Yes, sir.
Good evening. Thank you all for this wonderful evening. We had a superb lecture by Dr. Rex sir regarding the arthroplasty, and ASHA R ma'am about the infertility, and Ravi sir regarding the regenerative medicine, the course details and the course modules, and what are the fee structures. So how often we are doing the program. So all very nice manner. Our President Abul Hassan inaugurated this wonderful 3 IMA AMS fellowship course on arthroscopy, arthroplasty, and the infertility and the regenerative medicine. I thank you all the delegates and all the IMA leaders. Thank you once again. So we'll meet on August 5th again, our regular monthly webinar with a different topic like Alzheimer's disease and rabies. So thank you all for this wonderful. I thank you all our IT team and the Begin the Screen team. So thank you all. Have a nice day. Long live IMA, long live IMA AMS. Thank you, sir.
Thank you, sir.
Thank you very much, sir.
Thank you. Thank you.
Thank you very much.
Thank you.
Thank you, ma'am.
Thank you, Rajesh Babu.